Welcome to today's vodcast, Stepping Ahead, Proactive Foot Care in PAD and Diabetes Management. In this episode, we'll take a practical look at diabetic foot care, including prevention, risk assessment, and evidence-based strategies that can reduce amputations and improve patient outcomes. Diabetic foot care is a team sport involving healthcare professionals and the patient. Today's vodcast is designed for physicians, podiatrists, nurse practitioners, physician assistants, medical and podiatry students, as well as allied health professionals. Section 1. Why diabetic foot care matters. Foot complications are among the most devastating yet preventable outcomes in patients with diabetes. A diabetic foot complication is considered the single most common cause of morbidity among patients with diabetes. It is estimated that up to 25% of patients with diabetes will develop a foot ulcer in their lifetime, and up to 85% of lower limb amputations are preceded by a foot ulcer. The 5-year mortality rate after a diabetic foot ulcer or lower extremity amputation rivals that of many cancers, including prostate and breast cancer. Key statistics: 50% of foot ulcers become infected. 20% of infections lead to amputation. 70% of diabetic amputees die within 5 years. Section 2. Risk factors and classifications. Common risk factors for foot ulcer: peripheral neuropathy, peripheral artery disease, PAD, foot deformities, prior history of ulcer or amputation, poor glycemic control, inappropriate footwear, kidney disease, trauma, non-healing surgical wound. Classification tools: IWGDF Risk Classification, University of Texas Wound Classification System, PEDIS System, perfusion, extent, depth, infection, sensation. Section 3. The role of clinical foot exams. The mainstay therapy for intervention of diabetic lower limb complications has been to prevent the ulceration from occurring. Preventative care and screenings have demonstrated the ability to lower hospital admissions, prevent amputation, and lessen the financial burden of diabetic foot ulcer treatment. A comprehensive diabetic foot exam should be performed at least annually or more frequently for high-risk patients, such as every 3 months for at-risk foot care by a podiatrist. Components of at-risk foot exam include inspection, skin integrity, nail health, deformities, signs of infection, vascular, dorsalis, pedis, and posterior tibial pulses, ankle brachial indexes, capillary fill time, neurologic assessment, 10-gram monofilament plus tuning fork, 128 Hz, pinprick, temperature, light touch, proprioception, footwear evaluation and consideration for diabetes extra-depth shoes with plastizote insoles. Screening tools: Semes Weinstein 10-gram monofilament, VPT, vibration perception threshold using biothesiometer, handheld Doppler. Section 4. Wound prevention and patient education. Prevention starts with education and behavior change. This includes patient instructions, daily foot inspection using mirrors if needed, washing feet with lukewarm water, avoid soaking, moisturizing dry skin, avoid between toes, never walking barefoot, even indoors, inspecting shoes before wearing, test bathwater temperature with a thermometer or elbow, not with a foot. No bathroom surgery at home, such as using a razor for calluses. Go to a podiatrist for proper nail and callus care. Look for drainage on socks which suggests a possible wound. Avoid salicylic acid or corn removers. Look for changes in skin color, slow healing wounds and blisters. Call the podiatrist for evaluation and consult appropriate healthcare specialists. Educate on fall prevention. Consider gait training with physical therapy. Footwear tips: well-fitting shoes, extra depth and width. Avoid socks with seams or tight toe boxes. Medicare Therapeutic Shoe Program for qualifying patients. Buy shoes in the afternoon or evening when the foot is more swollen. Foot size and shape changes with age. Have the shoe size properly measured by a professional. Section 5. Managing the at-risk foot. For patients with identified risk, consider referral to podiatry for ongoing foot care, custom orthotics or diabetic insoles, offloading devices, total contact casts, walkers, or orthotic boots, ABI testing or toe brachial index (TBI) for PAD detection. Note: multidisciplinary foot clinics have demonstrated a reduction in amputation rates by 45 to 85%. Section 6. Infection, ulcers, and urgent referrals. If you see a foot ulcer, especially with signs of infection, erythema, warmth, purulence, act fast. Order appropriate labs, CBC, BMP, ESR, CRP, culture, X-rays. Mark the edge of the redness. And mark the date to monitor if the infection is resolving or worsening. Take vital signs. An individual with diabetes may not have a fever as they are immunocompromised. Sepsis can occur very fast. If a patient with neuropathy tells you they have pain, there is a potential infection. If their blood sugar is high, there's a possible infection. Infection severity, IDSA classification: mild, superficial, limited to skin, moderate, deeper or more extensive, severe, systemic signs or metabolic instability. Red flags for urgent referral: gangrene, osteomyelitis, probe to bone test, MRI, rapidly spreading cellulitis, ischemic limb. Management may require wound debridement, autolytic, enzymatic, surgical, offloading, total contact cast, cam walker, crutches, wheelchair, etc., culture-guided antibiotics, revascularization consults, appropriate wound dressings based on wound condition. Determining a deeper infection. Osteomyelitis. Looking at the cumulative picture is imperative. Probe to bone is 50% accurate if positive for osteomyelitis. Biomarkers have varying reliability. MRI imaging is more sensitive but not specific. Therefore, it is important to look at the overall picture of the patient and the foot to determine if osteomyelitis is likely present. The gold standard for determining osteomyelitis is a bone biopsy. Abscess, fluctuance to the area. MRI imaging indicating an abscess is present. Purulent drainage. If crepitus is felt, CT or XR may show gas gangrene. Immediate hospitalization and surgical intervention is needed. Septic joint. Elevated biomarkers. MRI shows signs of septic joint. Joint exposed in physical exam with purulent drainage. Significant or increased pain with range of motion with a joint near an ulceration. If there is concern for a deeper infection, an urgent consultation or hospitalization may be required. Conclusion and call to action. Diabetic foot care isn't just about feet, it's about saving lives and preserving mobility. With early detection, preventative education, and coordinated multidisciplinary care, we can change the trajectory for millions. Call to action. Integrate foot screenings into every diabetes visit. Refer high-risk patients to specialists such as podiatrists, vascular surgeons. Refer those with wounds to wound care centers for integrated advanced care. Educate your team and empower your patients. Let's help our patients step forward with confidence. For additional references and foot screening tools,